morning, everyone. Thank you, Camilla. Thank you to the organisers for having me. I'm delighted to contribute to this event. So what I'll do with this presentation is more cover ideas, models for how I think psychedelic therapy works therapeutically, and how psychedelic drugs work in the brain more generally. And so let's start with the definition. We could start with the etymology, the term itself, psychedelic, conjoining a couple of ancient Greek words, one for soul, most accurately psyche or mind, and this other component referring to making manifest, revealing, or making visible. And so it was a British psychiatrist working actually in Saskatchewan in Canada, Humphrey Osmond, the man famed for turning on Aldous Huxley by giving him mescaline. And he came up with this term, psychedelic, and actually it was in correspondence with Aldous Huxley that he did. But both men believed that the, at that time, existent terms didn't really capture the core property of what these compounds do. Hallucinogens, psychotomimetic were more specific, referring to certain perceptual effects, or referring to their ability to induce aspects of psychotic symptomatology. But psychedelic, in their view, got to more of the core, that these are compounds that reveal aspects of our minds or souls that are ordinarily not visible to us. You can see the molecular structure of some classic tryptamine psychedelics there. I'm missing mescaline, sorry Mike, it should be in there. It's a classic psychedelic. In a moment we'll look at how we define those by their pharmacology. The first thing to say is how similar the molecular structure of these tryptamine psychedelics are to the famous neuromodulator serotonin, 5-HT, 5-hydroxytryptamine. So that they look similar to serotonin, like so many drugs, is a hint at how they work on our bodies, that they mimic this naturally occurring chemical, and they hijack an aspect of the serotonin system. So what is that aspect? Well, we know classically that the serotonin system is especially complex as a neuromodulatory system with its 14 plus different receptor subtypes. But there's one of those that we know is critical to the action of psychedelics. If we block it with an antagonist, people won't trip. If we look at the affinity of a classic psychedelic for this receptor, it correlates very strongly with its potency. So LSD, very high affinity for the serotonin 2A receptor, incredibly potent. You can see the regional distribution of these receptors with this PET image here on the left. They're very much cortical receptors, and of course humans have so much cortex. And then speaking again in a hierarchical sense, they are distributed not entirely homogeneously in the cortex. There's more expression in high-level association cortex. I've got a little clicker to try and keep me to time that ticks over the slides. So I'll be, but it's useful because I have a habit of going over time. Now we could also look at this chart plotting the percentage occupancy occupied by different doses of psilocybin of the serotonin 2A receptor and the relationship with intensity. And the reason why I show this chart, it's relatively fresh and important data, is that it's hinting at a non-linearity in the serotonin 2A system, that you get over a certain proportion of occupancy, and quantitatively and likely qualitatively as well, the experience becomes something other. And it's important to emphasize in the above the threshold in which we see this kind of inflection point, around 20 milligrams and plus of psilocybin, which is the drug being given here. This is the therapeutic range that's currently being used in depression, addiction, and other clinical trials around the world. So we know that the 2A receptor is important, critical really for the action of these classic psychedelics. So what does it do? Why do we have it? Well, there's a wealth of evidence, as we know, to link the serotonin system to plasticity, the ability to adapt or change, and particularly the 2A receptor, that if we look at agonism of the 2A receptor, an association there between an increase in markers of neuroplasticity, particularly in the cortex, so a doubling of BDNF in the cortex. Synaptogenesis, recently shown very compellingly in this Cell paper. You can see the schematic there. Also, the involvement of the 2A receptor in brain development, learning and extinction learning, and also cognitive and psychological flexibility. So all these different aspects of the ability to adapt or change are modulated by the serotonin 2A receptor. I like this chart here from the work of Harvey et al., which is showing that blocking the 2A receptor will impair blunt learning or learning rate in low-level associative learning, whereas the administration of LSD enhanced that learning rate. It's an important principle shown quite elegantly there. So then moving on really again to this question of why we have those receptors, why they evolved, and if they're involved in adaptability, then why and under which conditions would we need to be especially plastic and adaptable? Well, it stands to reason that in conditions of adversity, special adversity, we might need to engage this system when literally perhaps our lives depend on that ability to adapt. So there's a wealth of evidence that's sometimes overlooked to link stress with an upregulation of serotonin 2A receptor functioning. This paper by Kevin Murnane very much speaks to that, and it's something that I've written about myself with David Nutt, for example, about the role of the 2A receptor in adaptability to adversity. I'm also interested in introducing this notion of pivotal mental states, which again is on this theme of adaptability and adaptability under extreme conditions. And these are hyperplastic states, I hypothesize, that can come about through a significant upregulation of 2A receptor signaling. And these are conditions in which we may be especially sensitive to contextual factors, and we may be especially sensitive and vulnerable to pivoting either towards psychopathology or towards positive therapeutic outcomes. And this is a model, I think, that's useful to help us think about how psychedelic therapy works. And before we go on to the clinical findings with psychedelics in clinical trials, I'll just address the safety profile of a specific psychedelic, which really is the main classic psychedelic that's being invested in, and efforts to develop this to marketing authorization currently. And so if we look at psilocybin's addiction potential, it's really negligible. Animals do not self-administer psilocybin. Psychedelics more generally, the classic psychedelics, seem to be fundamentally aversive, if anything. So they're not classic, hedonic drugs. People don't take them for the usual kind of feeling good, sort of rewarding effects. It's more of a sort of explorative rationale for doing it. The toxicity profile is incredibly good, a huge therapeutic window with psilocybin. You compare that to a lot of current medicines and legal drugs, and it's really, dwarfs those in terms of its therapeutic index. So we can look at some of the true risks: dysphoria, anxiety, the so-called bad trips. We prefer, as our peers working in this space generally do, to refer to them as challenging experiences rather than bad trips, because these challenging experiences often seem to mediate profound therapeutic outcomes if properly mediated. Yet those risks remain, and these are risks that, of course, are more serious and significant when people abuse psychedelics, taking them outside of appropriate context and then getting into trouble through, for example, injurious behaviors. I put a question mark over iatrogenesis. It's a specter that hangs over psychedelics. People think, aren't these compounds that can trigger prolonged psychoses? And you do hear of these very rare cases. Perhaps they're being averaged out, perhaps There's a self-selection bias in the data that we have at the moment, even the meta-analyses, but the cases seem to be so rare, hence the question mark. I think these cases do happen, perhaps we're missing them. Our team are currently thinking about ways to try and look at that bottom margin, those outliers, those very rare cases where there does seem to be a worsening of psychological well-being. But it's a challenge to do that, it seems, at the moment. So the risk seems to be very small, but it's probably real. We can also look at some of the side effects that are reported in the current trials. Headaches the next day and also the subsequent day are quite common, actually. In about 40% of patients, they appear to be dose-dependent. People will say they have a relatively mild to moderate headache the next day. They might take some pain medication and feel fine. You put that in the context of the clinical work that's being done, if they have treatment-resistant depression, for example, and they'll happily say, look, I'll take a headache over, a decade or so of crippling depression. But nevertheless, it's there, it's real, and it's worth thinking about. David Nutt's classic scale of harms, just to place magic mushrooms, which is where we find psilocybin and psilocin occurring naturally down at the bottom of this rating scale of harms to self and others, with alcohol up at the top there. So what of the latest clinical findings? And so this, in a sense, could be a talk in itself, and this is often where I run the risk of going over time. So instead, I just try and summarize these findings these days. And there are a couple of take-home messages. The improvements in psychological outcomes appear rapidly in our depression trial. You can see that chart there with all of the patients plotted. The improvements in depressive symptomatology were rapid. Everyone dropping to some extent 1 week post-treatment. After the second dosing session, a high-dose session with 25 milligrams of psilocybin. And also the effects appear to be enduring. Remember, or perhaps I should emphasize, that this isn't a classic pharmacotherapy model. People aren't on the psilocybin chronically over a period of weeks or months. These are 1, sometimes 2 treatment sessions. The drug is well out of the body, and yet people are reporting these improvements in depressive symptomatology, well-being, other aspects of psychopathology improvements there that appear to be very enduring. And so this is, of course, a challenging model. Where else in psychiatry do you see that kind of effect? ECT, perhaps, but not many things, and even ECT is repeated, of course. So these are another thing to note before I move on is that there's a few different disorders being looked at here: addictions and broadly addictions, alcoholism, tobacco addiction, also opiate addiction, cocaine addiction. These are all being looked at with very promising findings. And then depression, both major depressive disorder, treatment-resistant depression. Hopkins are currently looking at anorexia. We're about to start a trial in anorexia, chronic pain. Fibromyalgia came up. We also have a protocol to begin a trial in chronic pain, as others do as well. So there's this appeal to a potential transdiagnostic mechanism with psychedelic therapy, which again speaks perhaps to why this is a particularly exciting modality. And it's classically biopsychosocial. It's not just a drug. There's psychological preparation, there's supervision, and music. In all of those studies I was citing here, everyone listened to music. We call it the hidden therapist. While the therapy itself is non-directive, it's quite hands-off, there is some direction, but it's implicit, and it's there with the music. But this is very much a hybrid model combining manipulation of context in a way that we think is optimal for this very vulnerable and sensitive state induced by the drug. But it's very much about that combination, that synergistic, assumed synergistic space where these things meet. And to put a bit of meat on the bone about these strong assumptions that we hold about the importance of set and setting, as Mike nicely explained, we've been doing some naturalistic observational work, trying to collect big data through this platform, psychedelicsurvey.com. And one of the flavors of the surveys that we do looks at ceremonial use. Someone said putting a new spin on group therapy. Indeed, in fact, it's a kind of old spin because people have been taking psychedelic plant medicines for countless generations. But here we're using the natural use of plant-based psychedelics in these contexts, sometimes ayahuasca, often mushroom retreats as well, to look at these different factors. And here we can see some significant predictors of a certain kind of experience where people report strong emotional catharses or breakthroughs, these being predicted by the personality trait absorption, therapeutic intentions, emotional support seems to be especially important, and listening to music, all mediating these cathartic experiences that are then predicting positive psychological outcomes into the longer term improvements in psychological well-being in this case, as we were looking at a very general population. But the same thing would be true if we were isolating people with high baseline depression scores, for example. So it's one way to test set and setting, and it is difficult to do that. No one really wants to provide a suboptimal context if they're giving a potent psychedelic drug to vulnerable people. So it is a useful way to do it, and of course, as we go forward, we'll develop confirmatory studies to test these assumptions more thoroughly. But just speaking to that notion of emotional breakthrough, that construct, which we believe and now have data to say is very important. It's a key mediator of these therapeutic outcomes. If you go through having emotional breakthrough, then you're much more likely to have these positive therapeutic outcomes. So these are just a couple of patient accounts from our depression trial that speak to what we think of and now measure as emotional breakthrough. I was weeping, tears were flowing out of me. It wasn't a painful crying, it was like a turning on the taps, like a washing out. Another volunteer saying, I saw patterns in my life where if something bad happens, I used to just put it to the back of my mind, but afterwards, after the treatment, I allowed myself to experience everything, even if it is sadness. Now I know how to deal with my feelings rather than repress them. So as I said earlier, one of the exciting things about psychedelic therapy is this potential that they may target something in the Venn diagram of psychopathology where there is significant overlap. And here I'm suggesting, as others have, that it's in this space of aberrant habits of mind and behavior. You can think of aberrant habits of behavior, of course, in addictions very clearly, but we can also think of the negative cognitive bias in depression that is a sort of pseudo addiction in a sense, that it's like an attractor, it pulls you down, it draws you into it, and then it becomes very rigid and difficult to escape from that rut. And we can also think of the same thing in terms of obsessions and compulsions, obsessions in eating disorders and image disorders, and also aspects of pain where there is this substantial psychological component that's so difficult to shake. So this is the space that I'm arguing that psychedelic therapy comes in, and it shakes up these habits of mind and behavior. It induces a window of relaxation of those overweighted habits, and that provides an opportunity for working on their long-term revision. So this is an abrupt segue, if you can have an abrupt segue, into focusing on the acute brain effects of psychedelics and our brain imaging work in this space. This is a popular image which is looking at how different communities of brain regions that are usually quite cliquish in their communication, parts of the visual system will be speaking mostly to other bits of the visual system, doing its modular function in the way that it does. But under psychedelics, we see this interesting crosstalk, intermodular crosstalk, which is really nicely illustrated in this image here. We also showed it In a different way with LSD and fMRI, where we're asking here essentially where in the brain is speaking most synchronously, most strongly with the primary visual cortex, and under placebo conditions, it's mostly other bits of the visual system at the back of the brain. Yet under LSD, we see that most of the brain is now synchronous in its activity with the V1 component of the visual cortex. And this effect correlated with complex imagery. People often talk about psychedelics as being hallucinogens, but that's slightly misleading. People don't typically see things that aren't there. They see perceptual distortions with their eyes open, but eyes closed, the imagery is incredibly vivid and rich. And so these are, in this case, people are rating the vividness of the complex eyes closed imagery. These are eyes closed resting state scans, and it's correlating very strongly with this increase in the connectivity profile of V1. We can also look at the integrity of resting state networks. Here we're looking at the default mode network, but this is just one example of most intrinsic brain networks that show a decrease in their functional integrity under psychedelics, a very reliable finding across studies, across teams with different psychedelics. Here I've shown the default mode network because there's this interesting correlation that others have shown as well now between ratings of ego dissolution and disintegration in this particular system that makes sense given what we know about the default mode network and its relationship with self-referencing, imagination, and these functions that you might associate with self or ego. We can also look at the rhythmicity of the brain and that dominant alpha rhythm that's so pronounced in our species and becomes all the more pronounced as we mature into adulthood. So a bit like the default mode network, one of these signatures of high-level brain function, at least it's most pronounced in our species, and it undergoes these important developmental changes. And yet there was this collapse in the alpha rhythm. Again, this is arguably the most replicated finding in psychedelic brain imaging, this very dramatic drop in alpha oscillations, alpha power. And here again, we're seeing it correlating with ego dissolution. And so the entropic brain idea is really a very simple principle related in some sense to the integrated information theory of Giulio Tononi, his theory of consciousness. And it's kind of the information component. And so really it's saying that the entropy or the unpredictability of spontaneous brain activity, here measured with EEG, we can also measure it with other modalities, will give us information about the richness of conscious experience. If we lose conscious awareness, we fall asleep, we have a brain injury, we're under an anesthetic, then the entropy of brain activity drops. It becomes more predictable, and consciousness is lost. Until recently, it was thought that the richness, the entropy, the unpredictability of brain activity was maximal during normal waking consciousness. And yet, when we tested psychedelics in this context, we saw an elevation above the already very entropic quality of brain activity in normal waking consciousness. Range of different psychedelics, and it correlated with the intensity of the subjective experience. So this is really intriguing to think, perhaps, in states of unconsciousness, you could introduce a psychedelic to return consciousness. It's a very intriguing idea, but it's also a very simple principle that seems to hold up and be useful. And so the last model that I want to introduce, which is more or less as far as we've got in terms of hypothesizing the global brain effects of psychedelics, is this model which is inspired by a dominant model in cognitive neuroscience that most of you will be very familiar with, and increasingly so in psychiatry as well, hierarchical predictive processing. So it's the ability of our minds and brains to take shortcuts for efficiency, to read text like this, even though the letters are jumbled up, the first and the last are in order, and so most of us, I think, can can read this. I should really credit where this came from. I'm not sure who came up with it, but it certainly wasn't me. And also images like this, I sometimes say movies like this, to try and enhance the effect. Of course, there isn't any motion here at all, and yet many of you in the room are probably hallucinating some motion because you see something like this in the world. Typically it would be moving, so it calls up our predictive models inside our heads, and that's what we perceive. So it really speaks to how our minds and brains work. You'll hear much more of this, probably more elegantly from Paul Fletcher and others later on. But this is the simplest way I'd show it in a schematic, that based on the hierarchical organization of our brains that is so well established, higher aspects of brain will impose predictive models on incoming sensory information, and in healthy conditions, most of our experience of the world will be dominated by these internal predictive models rather than the sensory information coming in. But there's a relatively healthy weighting that you would expect in a healthy brain, with some, more dominance on the level of the predictive models. But what in psychopathology, or at least a large proportion of psychopathology, this strong priors model, I think, this is the kind of space in which I think psychedelic therapy holds so much promise, where beliefs, assumptions, habits of mind and behavior have become so bedded in that to treat them, we really need to de-weight them and then seize that opportunity therapeutically. So an overweighting of these predictive models. And this may well speak to this common theme that you see written about so much in kind of pop psychiatry, I suppose, the likes of Johann Hari's Lost Connections, Bruce Alexander's dislocation theme in relation to addiction, this notion of a disconnect and alienation that underlies so much psychological suffering. Here, one of our patients from our depression trial speaking to that, someone who very much, when well, enjoys orchids, saying, I'd look at orchids and intellectually understand that there was beauty, but I couldn't experience it. So, as I've said already, the model is about this de-weighting of these overweighted, pathologically overweighted models that occurs during the psychedelic experience, and then provides this opportunity for a healthy revision of those overly weighted habits. And so evidence that speaks to the model, we can look at current evidence out there from functional brain imaging. We've got some exciting data in the works looking at gradients in the intrinsic brain networks, also traveling waves, which very much supports the hypothesis. We can look at those nice intuitive examples of hierarchical predictive processing, optical illusions, and see that their diminished effect under psychedelics, binocular rivalry ordinarily will suppress out one of the competing images and just see one, but you see much more occurrence of dual percepts under psychedelics. We could just look at the phenomenology as well to see the intuitive appeal of the model in terms of ego dissolution. What's that if not the breakdown of a very pervasive belief assumption that we have about ourselves, and the emotional sensitivity and cathartic experiences that you see with psychedelics. What's that if not the release of information that's ordinarily suppressed out of consciousness? So this is the penultimate slide before my acknowledgements, which is really, speaking to the ideal for the therapeutic model. And you see so many of these reports. They're so common both in the healthy volunteer studies that we do and also in the trials in depression. A veil dropped from my eyes. Things were suddenly clear, glowing bright. I looked at plants and felt their beauty. I can still look at my orchids. This was some 6 months now on from the treatment with psilocybin for treatment-resistant depression, and experienced that. That's the one thing that's really lasted. So we have this, our TRD trial, treatment-resistant depression trial, was very limited in terms of rigor. It was an open-label trial, very small sample size, And a lot of those studies that I was citing, the main limitation there is, yes, they're very small samples. This is a double-blind RCT in 60 patients going head-to-head with a leading treatment for depression. Get ready for the results because they're really exciting, looking at the preliminary data in 40 of the 60 patients so far. This will really help calibrate, all the excitement that you're hearing from people like me about the promise of psychedelic therapy. How good is it really in relation to the best that's currently out there? So thank you very much for your attention. Thanks to the team, and thanks, all of our work really almost entirely has been supported by philanthropic money, allowing us to do explorative research. It's been very difficult to win mainstream funding for this research, but those individuals have made it possible, so we're eternally grateful to them for doing that. Thank you for your attention.
Thanks for such an excellent talk. So we're a couple minutes over, but I think we have time for one question. Yes, right there.
Hi, just a question about the trials that you're running and how you can double-blind psychedelic treatment. I mean, presumably it's impossible to blind the patient and the person leading the therapy session. So how do you truly double-blind these trials?
Yeah, it's a great question. So it's almost impossible to blind effectively, because when you get 25 milligrams of psilocybin, usually you know about it. It might be one of the strangest experiences of your life. So that's impossible, I think. Maybe you could introduce a sedative as a control or a high dose of amphetamine, but it's never really going to quite cut it. What we have in the double-blind RCT is a few. It's a two-arm trial, but people aren't given the information about the permutations, so they think it's possible that they might get a high dose of psilocybin and be on escitalopram for 6 weeks, and they can't. And so there is some confusion, either when they get 1 milligram. That's another thing that we do. We don't give an inert placebo for the placebo dosing sessions that we compare with 25 milligrams of psilocybin. We give 1 milligram, and that allows us to standardize expectation, because we say everyone's going to receive psilocybin, which is true. It's just that the dose varies, and we don't tell them quite how much the dose varies. So that helps in terms of prior expectation, but absolutely, it's you typically everyone, more or less, not quite everyone, will feel 25 milligrams, and when they do, it's often a very big experience that breaks the blind.
Great. Well, let's thank Robin again, and we'll reconvene at noon for what's sure to be a really exciting talk from Paul Fletcher. Thank you.